So good afternoon, ladies and gentlemen. Thank you very much to staying late until this session outstanding free papers presentation. This year, in fact, not this year, it is last year that we have selected 4 outstanding free paper. Because last year, because of COVID-19, we have canceled the annual scientific meeting. That's why the outstanding free paper 2020 was postponed till this year. We apologize for that. So I would like now to hand over the chair to my colleague, Dr. Wency Ho.
Okay, so we start our next session. This session is the free paper presentation. Today.
Good afternoon. This is my pleasure to present with you my study on assessment of hip fracture outcomes in local geriatric population by the clinical frailty scale. Hip fracture is the most common cause of death from accidents in older people. More than 90% of hip fractures are resulted from falls, which are known as one of the geriatric syndromes. It is associated with mortality, functional decline, reduced quality of life, and institutionalization. There are different orthogeriatric care models with various degree of involvement of geriatricians. The combined orthogeriatric care refers to shared care of orthopedic and geriatric teams, where geriatricians are responsible for perioperative assessment and leading postoperative multidisciplinary care. This is associated with reduced mortality, length of stay, institutionalization, and improved functional outcomes. With the increasing understanding of frailty, it is advocated that geriatric syndromes are better mortality predictors than the presence of specific diseases. Among various frailty assessment tools, clinical frailty scale is well credited to be simple and reliable. It correlates with length of stay, functional decline, and mortality. Clinical frailty scale is scored on a scale from 1 very fit to 9 terminally ill to stratify elderly people according to the level of frailty. A score of 5 or above is considered frail. My study examined the relationship between local geriatric patients' premorbid status, frailty status assessed by the clinical frailty scale, and hip fracture outcomes, including 1-year mortality, discharge destinations, length of stay, and institutionalization as 1 year. So this is a retrospective cohort study conducted from January 2014 to January 2015. Patients aged 60 or above admitted to the orthogeriatric specialty ward in UCH are recruited. As a result, there was 731 patients in the study. Data was retrieved from the CMS, and SPSS was used for the statistical analysis. Patients were categorized into 3 CFS groups according to description: CFS 1 to 4 to the non-frail group, CFS 5 to 6 to the mild to moderately frail group, and CFS 7 or above to the severely frail group. More than half of the study population belongs to the non-frail group. For age distribution, more than 80% of them were aged 75 or above. This table illustrates patient characteristics. We can see that for the non-frail group, patients were less likely to have comorbidities like old stroke and old fracture, as well as history of fall. On the other hand, they are also more likely to be living alone or without a daytime caregiver. The overall mortality rate was 20% with male predominance. Compared with the non-frail group, patients in the severely frail group have significantly higher mortality with a hazard ratio of 3. For discharge destinations, almost half of the study population was transferred to Kowloon Hospital for further rehabilitation. Among those who were newly institutionalized on discharge from UCH, the mild to moderately frail group has significantly higher percentage compared with the non-frail group. So for the length of stay, patients who were transferred to Kowloon Hospital were recruited into the analysis. As a result, the mean length of stay of UCH plus KH was 38 days. The overall institutionalization as 1 year was 17.8%. However, there was no statistically significant difference among the CFS groups. In this study, 43% of the study population was aged 85 or above. This may be due to the higher fall risk and high prevalence of osteoporosis in the older population. 1 in 5 died within 1 year of acute hip fracture events, and males have doubled the mortality rates compared with females. The excess mortality in the male population may be due to the risk factors, including poorer premorbid health status and more postoperative complications. Compared with the non-frail group, patients who were severely frail had 3-fold increased risk of death. At the time of discharge, patients in the non-frail group were less likely to be institutionalized compared with those in the mild to moderately frail group. However, after 1 year, there was more than 5-fold increase in the number of institutionalized patients in the non-frail group. Why is that? Possible reasons include recurrent falls and inadequate home support, especially when more of the non-frail patients were living alone or without a daytime caregiver at baseline. Contradicting to other studies, there was no correlation between frailty status and length of stay in this study. This may be due to the selection bias, as patients transferred to Cowden Hospital were more likely to be medically stable, and therefore excluding those who with more postoperative complications. So what can we learn from this study? From our experience, clinical frailty scale serves as a practical tool to facilitate communication among professionals in the orthogeriatric care, as it correlates with adverse clinical formally targeted interventions for frailer individuals to lessen their risks, better stratify the risks in patients' management, provide more patient-centered information in communication with patients and their families, and therefore enabling more goal-directed care, and select the frail individuals for multidimensional geriatric care in both hospital and community settings in hopes of improving their clinical outcomes. In the long run, we may advocate clinical frailty scale as a routine screening tool in the provision of comprehensive geriatric assessment and interventions. However, this study is not without limitations. There may be confounding factors, including the types of medications used, surgeons' expertise, types of surgical procedures, and postoperative complications. There may also be discrepancy between the documented and actual number of deaths that were not recorded in the public hospital system. In conclusion, this retrospective study showed that patients' premorbid frailty status assessed by clinical frailty scale correlated with 1-year mortality and institutionalization on discharge from the acute ward in local geriatric hip fracture. As a simple and reliable tool, clinical frailty scale could be routinely used in the provision of comprehensive geriatric care. This is the end of my presentation. Thank you very much.
Thank you, Dr. Chen. Do you have any question?
Can we see any questions from the audience? Okay, it seems that there's no question. Wency, do you have a question? No, okay.
Yeah, I can have a question, Dr. Chen. So it seems that there is a strong correlation in terms of using a clinical frailty scale to predict the patient's outcome, right?
Yes.
So do you have any orthogeriatric services in UCH currently?
Yes.
So would you like to implement this kind of assessment in your daily practice?
Yes, actually, we have a specialized orthogeriatric ward in UCH with the collaboration between orthopedic teams and our geriatric teams. And we actually have been using CFS in our daily practice during our assessment for the communication with the orthopedic surgeons and also the PTOT and the analyst team. And we also have a weekly grand round to communicate our perioperative assessment and also the postoperative care. And so from our experience, this is well understood among various parties because it's very simple and a very practical tool. And we also encourage the use of CFS we hopefully can spread the message of CFS in other uses apart from orthogeriatric, maybe in other surgical wards or even general medical wards.
So currently, are the nurses or doctors doing the clinical frailty scale assessment?
Mainly from our geriatric team, but during the communication, then we may also share with other members as well.
Maybe we can have the second question from Dr. Christopher Lum. So we know that frailty can predict mortality and life expectancy. Do you think the study can be used as a guide to initiate the advanced care planning?
Yes, yes, sure. Thank you for the question. And we, after using the CFS, we may also to stratify the risk of the patients and to communicate with the patients and their families. And therefore, they may better understand the risks involved in the operation and also the whole hip fracture journey. So whether this may also guide our treatment goal and also rehabilitation goal, or even care planning goal in the long run. So it's very useful in the ACP planning.
Thank you.
Thank you very
So
much.
maybe we have the second speaker.
Maybe we have to move on. Thank you, Dr. Chen.
Thank you.
Speaker is Dr. Leung Pui. Dr. Leung is private, is working in the private sector.
So the speaker is preparing a slide, and his topic is automatic office waiting area blood pressure is a practical and reliable method of blood pressure measurement in Chinese older people in clinic setting in Hong Kong.
Thank you, Chairman. I'm honored to present our study on automated office blood pressure measurement in the waiting area in a clinic setting in Hong Kong. Hypertension is highly prevalent in older people. Optimal blood pressure control is important because it improves the cardiovascular risk involved. Blood pressure should be measured by a method which is free from white coat effect. This is even more important in older people because it is more common, and potential overtreatment by overestimating blood pressure can result in serious sequelae. Conventional office blood pressure measurement has been known to be associated with white coat effect and is not reliable. And this cannot be ameliorated even with the 5 minutes rest before blood pressure measurement and using the semi-automatic blood pressure machine that we are using nowadays. The gold standard of blood pressure measurement, ambulatory blood pressure measurement, however, is time-consuming, costly, and might not be available in clinic settings. We turn to home blood pressure monitoring, which is known to be more reliable. Automated office blood pressure measurement, or AOBP, has been more extensively studied and used in the past 10 years. The subject is seated alone in a single room. A fully automated blood pressure machine is used with automatic trigger. 3 to 6 blood pressure measurements were taken at intervals of 1 to 2 minutes, and the average blood pressure is then displayed. AOBP has been shown to be associated with less white coat effect and is therefore more reliable. The problems with AOBP is that it requires a single room, and it also leaves the patients unattended. To overcome the problems of limitation of space locally and the risk of leaving older people unattended for any period of time, we suggest that AOBP can be performed by seating the patient in the corner of a waiting area instead of in a single room, while all other elements of AOBP remains unchanged. We call this waiting area AOBP. We hypothesize that the elimination of white coat effect with AOBP is not related to the subject being alone in a quiet room. In our waiting area AOBP study, we recruited patients attending the private outpatient clinic for management of hypertension. We recruited older people over 65 years of age. 151 subjects were recruited during a 3-month period in 2019. The patient is first seated in the corner of a room, a waiting area. The clinic nurse will check the blood pressure after 5 minutes rest. This is the first set of data we collected. This is a COBP data. After that, the patient was left alone. After a 3-minute flush period, 3 consecutive AOBP readings were taken at 1 minute interval. We used the Oberon automated blood pressure machine, which has been validated. The average blood pressure displayed in the end of the measurement is taken as the waiting area AOBP data. And this is a second set of data that we collected. The patient is then requested to record the home blood pressure daily in the following 7 days on the chart provided. And the average of the data will be regarded as the third set of data. And this is the HBPM or home blood pressure measurement data. We then compared the 3 sets of data. 133 patients' data were analyzed, and mean age is 73.5 years, slightly more female than male, with a BMI of 24.5. 87% of patients had comorbidities, the commonest of which is hyperlipidemia. They were mostly clinically robust, and on average, they are using 1.7 types of antihypertensive drugs. This is the result. The COBP reading shows a systolic blood pressure of mean systolic blood pressure of 133.5. The waiting area AOBP data was 127.8, which is significantly lower than that of COBP. And this was shown to be comparable to the home blood pressure monitoring data of 126.2. This table shows the difference in the 3 sets of data. The waiting area AOBP data is lower. Sorry, the waiting area AOBP data was lower than the COBP data by 5.7 millimeters of mercury, which was statistically significant. However, the waiting area AOBP and the home blood pressure monitoring data were not statistically different. We then analyzed the data according to blood pressure subgroups with the 135 millimeters mercury as the cutoff line. For the lower blood pressure subgroup, the difference was 2.8 millimeters of mercury. Whereas in the higher blood pressure subgroup, waiting area AOBP measurement was lower than COBP by 9.3 millimeters of mercury. And this was statistically significant, which means that waiting area AOBP is more effective in eliminating white coat effect in patients with higher blood pressure. In conclusion, number 1, waiting area AOBP is effective in elimination of white coat effect, and as such, should replace COBP in the clinic setting. Number 2, waiting area AOBP is comparable to home blood pressure measurement in the elimination of white coat effect. There are advantages to each of them, and we suggest that one should not replace the other. And number 3, waiting area AOBP is more effective in the higher blood pressure subgroup. In places with resource restraint, this should be reserved for patients with suboptimal blood pressure control. And lastly, we suggest that waiting area AOBP might also be effective in settings outside the clinic, including the emergency room and the hospital setting. And further evaluation is warranted. Thank you.
Thank you for the presentation, Dr. Leung. I cannot see any questions from the Q&A area. Maybe I have a question for Dr. Leung. So as most of the guidelines for the target of blood pressure control are based on the maybe office type of blood pressure measurement. So how would you recommend the target blood pressure by using the waiting area blood pressure measurement?
For studies for AOBP, classical AOBP, the standard is set around 5 millimeters mercury, lower than the standard setting. So I think we should take this into consideration.
Okay, thank you. Thank you. Can we see any question from the Q&A area? If no question, we can proceed to the third speaker. Thank you, Dr. Leung.
Thank you, Dr. Leung. So we now move to the third outstanding free paper presentation. So the third speaker is Dr. Tam Yuen. So she is working in Yuen Hospital. The topic of her presentation today is intravenous thrombolysis in elderly patients with stroke, young old versus old.
Good afternoon, distinguished guests. I'm Dr. Ellen Tam from Yuen Hospital. Today, I'm here to present my study on intravenous thrombolysis in elderly patients with stroke, young old versus old. Stroke is a well-known global leading cause of morbidity and mortality, and its incidence increases with age. Stroke in the elderly over 80 is also known to be associated with higher mortality and more complications. Intravenous thrombolysis with tissue plasminogen activator, or IVTPA, is currently the mainstay of reperfusion therapy for acute ischemic stroke, with proven evidence to reduce stroke-related disability and mortality when given within the therapeutic window of 3 to 4.5 hours. Although advanced age is not an absolute contraindication for IVTPA, clinical trials have traditionally excluded or underrepresented very old patients over 80 years old. The aim of this study is to compare stroke outcome and complications after IVTPA between the young old, age 65 to 79, and old, age 80 or above, and to test for their associated prognostic factors apart from advanced age alone. This is a single-center retrospective cohort study with data collected from the Yuen Hospital Stroke Registry between 2015 to 2017. All elderly patients aged 65 years or above who are given IVTPA before acute ischemic stroke and then further managed in Yuen Hospital within the period were recruited. Exclusion criteria included younger adults and if there were other means of thrombolytic therapy given, for example, intra-arterial or mechanical thrombectomy. The primary outcome was a favorable stroke outcome, which was defined as a 3-month modified Rankin score of 0 to 2. Modified Rankin score, or MRS, is a very well-used assessment tool for stroke outcomes, ranging from 0 asymptomatic to 5 severely disabled, while a score of 6 refers to death. And a score of 0 to 2 here reflects functional independence. Secondary outcomes include any kind of post-TPA intracranial hemorrhage, mortality of index admission and at 3 months, the length of stay, use of non-oral feeding upon discharge, and the need to move from home to institution. The association between the prognostic factors and above outcomes would be investigated. A total number of 248 cases were recruited. 144 of them were young old, 104 of them were old, with the oldest being 96. Premorbid MRS ranged from 0 to 4, which means chair-bound. NIHSS, which reflects stroke severity, ranged from 0 to 33. And the onset to needle time ranged from 45 minutes to more than 5 hours. The following shows the baseline characteristics of our patients. Not surprisingly, the older patients presented with worse functional status, more comorbidities, and also a more severe stroke at presentation. For the primary outcome, significantly more patients in the young group were able to achieve functional independence at 3 months. The following shows the 3-month distribution of the MRS score between the two groups. So a generally worse outcome can be appreciated in the older group of patients. For the secondary outcome, the rates of post-TPA ICH were not significantly different between the two groups. Both index and 3-month mortality were significantly higher in the older group. Almost 1/3 of the old died at 3 months. The length of stay did not differ. More patients in the old required use of non-oral feeding, as well as moving to old age home upon discharge. Multiple logistic regression was performed. A favorable stroke outcome was found to be associated with younger age, better primary functional status, and also less severe stroke at presentation. Symptomatic ICH was associated with older age and a previous history of stroke. A more severe stroke of NIHSS over 25 and longer onset to needle time over 3 hours were associated with both index and also 3-month mortality. The following covers the discussion part. First, when compared to other overseas studies, less patients in our study were able to achieve a favorable stroke outcome, while the rates of symptomatic ICH was higher. Possible reasons were that our patients recruited were older, were more dependent at baseline, and presented with more severe stroke compared to those studies. Also, Asians were known to be more prone to post-TPA ICH. While our study showed a positive association between advanced age and ICH, current evidences on the association between the two are actually contradicting. Mortality of both groups of patients are comparable to those from larger studies and was significantly higher in the old. However, upon multiple logistic regression, advanced age was actually not significantly associated with mortality. Rather, a very high stroke severity and extended onset to needle time were associated with both inpatient and 3-month mortality. Cautious case selection is therefore required when we decide for treatment, especially when, according to guideline, class 1 evidence only suggests IPTPA to those younger than 80 years old and with NIHSS score less than 25 when the onset time falls beyond 3 hours. One strength of our study was that there was no selection bias as all patients given IPTPA were recruited. There were minimal missing data. This study helped fill some of the knowledge gaps as there is limited local data on the use of TPA on the very old, and even less data on the outcome on those given TPA outside conventional guideline, like those with extended onset time and very high NIHSS. There are certain limitations, however. First of all, this was a retrospective cohort, and so a causal relationship cannot be proven between the prognostic factors and also the stroke outcomes. Also, a control group was not recruited of those not given TPA. And so the reason of them not given TPA as well as their outcomes were actually unknown. And this was just a single center study, while practices and case selection may differ quite a bit between hospitals or clusters affecting potential outcomes. One of the implications of this study is that we have shown that young age data should not be implied to predict post-TPA stroke outcomes in the elderly. Though not necessarily due to the TPA, the old had significantly worse stroke outcome. So a specific database, for example, like this kind of visual decision aid, might be developed specifically for this age group to guide our medical treatment plan. Another implication of the study is that there are certain functional outcomes, for example, cognitive function, the ability to communicate or tolerate oral feeding, etc., that are not reflected in the MRS score, but still carry implications on an elderly's care plan and quality of life. In view of such, preserving existing functions may be a more practical target rather than to aim for a numerically favorable MRS score in stroke management in this group of patients. To conclude, the study has shown that when compared to young old patients beyond 80 presented with less favorable stroke outcome and higher mortality after receiving IPTPA, while often advanced age was not the only risk factor. Rates of ICH were similar, although age over 80 was found to be associated with symptomatic ICH. Severe stroke with NIHSS over 25 and prolonged onset to needle time over 3 hours were independently associated with inpatient and 3-month mortality. That's the end of my presentation. Thank you.
Thank you, Dr. Tam. So we had one question in the Q&A area. So really challenging, not the question, but to my eyesight. I hope I can read it out clearly. As baseline ranking score differed between groups at baseline, it was not surprising that absolute ranking score modified ranking score also differ between groups at 3 months. Were there differences in change of this modified ranking score between the two groups? Okay.
This is a very good question. We also asked this kind of question when we were preparing for the study, but because most of the international studies used our primary outcome, the 0.022 MRS as their outcome. So in order to compare with those studies, we use this outcome as well. I do agree that maybe next study, we could use the change in the MRS score or change in functional status to better delineate their change of outcome.
Thank you. I have a second question for Dr. Tam. What do you think about the use of or application of PMORBID clinical failure scale or failure index in helping the discussion of the outcome of thrombolytic therapy?
I think it's very useful actually, because when we plan treatment for patients, there is known risk and there are known complications like ICH, and we need to balance the risk and benefits. So if the potential benefits of the thrombolytic therapy is actually minimal, for example, in those with severe, like very frail or even bed-bound patients, then the risk would outweigh the benefits. And this is also a basis that we could discuss with the family, like what the potential benefit may be according to their frailty score.
So thank you, Dr. Tam.
Thank you.
So we move on to the fourth free paper presentation. So the fourth speaker is Dr. Jacqueline Yuen. She is working in the Hong Kong University. And also this morning, she is also an invited speaker to talk about careful hand feeding. So she already taught us a lot this morning. The topic of her presentation is about the impact of feeding mode on survival and 28-day hospital readmissions in patients with advanced cognitive impairment with feeding problems. This is a retrospective cohort study. So we pass the time to Dr. Yuen. Thank you.
So good afternoon. It's my pleasure to share the findings from my study on the impact of feeding mode on survival and hospital readmissions in patients with advanced cognitive impairment with feeding problems. In patients with advanced dementia, feeding problems are nearly universal. And there are different types of feeding problems that we observe. One is a physiologic feeding problem, where these patients have chewing and swallowing problems leading to oropharyngeal dysphagia. The other type of feeding problem can be categorized as behavioral feeding problem. And these patients may develop apraxia or visual spatial dysfunction, which leads to poor food intake or food avoidance. Oftentimes in late-stage dementia, the persistence of these feeding problems often lead to the consideration for long-term enteral feeding. Prior observational studies have not found conclusive evidence that feeding tubes prevent aspiration pneumonia or prolong survival in patients with advanced dementia. However, many of these prior studies have major methodological flaws, including selection bias, poor inclusion and exclusion criteria. And when trying to apply the existing evidence to our patient population in Hong Kong, these studies actually are less generalizable. One reason being that many studies study patients with PEG tubes. However, in Hong Kong, many of our advanced dementia patients are using nasogastric tubes. Another difference is that many of these studies focused on community-based advanced dementia patients. However, given that nasogastric tube insertion decisions are often made when these patients are hospitalized, it would be important to look at outcomes for these patients starting from the point from which they're hospitalized and the decision arise for nasogastric tube insertions. And another limitation of earlier studies are that they lack information from assessments of speech therapists as to the nature of their feeding problems. And so for my study, some of the study aims included determining the impact of nasogastric tube feeding versus oral feeding on survival amongst these patients with severe cognitive impairment with feeding problems. Another aim was to determine the clinical and demographic predictors of survival for these patients, and also to compare the readmission rates between patients who were placed on nasogastric tube feeding versus oral feeding. A retrospective cohort study was done, and we identified patients with severe cognitive impairment who were admitted from January 2015 to June 2019 to 2 geriatric convalescent hospitals in the Hong Kong West cluster, and who were considered for nasogastric tube insertion due to feeding problems during the index admission. The patients were categorized into 2 groups. The group that, after a discussion between the doctor and the patient's family member, decided for nasogastric tube insertion, and the group that opted not for NG tube and opted for careful hand feeding. We excluded patients who had existing feeding tube, acute stroke, cancer, who were comatose, and who had a tracheostomy. So this table shows the baseline characteristics of our patients. In the end, we enrolled 872 patients. On average, these patients were quite elderly, with an average age around 90 years old, with 75% who were residents in OH homes. There were some significant differences that were found amongst the patients who had NG tube inserted and those who didn't. These included that the NG tube group had higher rates of having pneumonia on admission. The NG tube group also had a higher prevalence of the feeding problem type being dysphagia, or both behavioral and dysphagia. And the severity of dysphagia was higher in the NG tube group. The NG tube group also had higher ADL independence. And we also found, in terms of prevalence of advanced care planning and DNA CPR order for non-hospitalized patients, were higher in the group that opted for careful hand feeding. So this graph shows the survival rates at 6 months, at 28 days, 6 months, and 1 year. And we found no difference in survival rates between the 2 groups. And the 6-month survival was around 45%. So we did a Kaplan-Meier analysis and found that overall survival also did not differ between the 2 groups, with median survival of around 120 days. To assess for prognostic factors for mortality, a Cox regression analysis was conducted. And the factors that predicted mortality were male gender, low albumin level, low lymphocyte count, presence of active pressure ulcers, and having a diagnosis of aspiration pneumonia on admission. And we also assessed for the influence of the feeding mode and found that feeding mode did not influence mortality in our analysis. And finally, we compared the readmission rates between patients who were placed on NG tube and who opted for oral feeding, and found no difference in their readmission rates at 28 days, 6 months, and 1 year. However, the readmissions rates were notably high at all of these time points. So in conclusion, we found in our study that high mortality rate was noted amongst these patients with severe cognitive impairment who were hospitalized with feeding problems. This was consistent with many of the existing studies as well. Another finding that actually was consistent with existing studies was that the choice of feeding mode did not impact on survival. So the prognostic factors for mortality were gender, the albumin level, the lymphocyte count, active pressure ulcers, and having a diagnosis of pneumonia. And we found that both patients in both feeding modes had similarly high rates of readmissions. So thank you. This is the end of my presentation.
Thank you, Dr. Yuen, for your presentation. So there seems to be no question from the Q&A area. maybe I ask the first question. Now, many times, what prevents the clinician to continue careful hand feeding could be dehydration or impaired renal function. So, in your retrospective analysis, did you look into the renal function of the two groups? Because I understand that the survival are similar between oral and non-oral group. So what any finding about the renal function?
Look at the renal function, but you're correct in that we did look at the reason why these patients were readmitted. Interestingly, so the main reason for both groups was recurrence of pneumonia. However, for the secondary and third reasons, for the NG2 group, they were primarily due to dislodged nasogastric tubes or GI bleeding. And for the oral feeding group, it was dehydration, decreased general condition. But even in those groups, the reverting back to NG tube for the oral feeding group was actually quite low.
Thank you, Dr. Yuen. Dr. Ho, do you have a question?
Thank you, Dr. Yuen, for your presentation. So it was known that actually there was a meta-analysis in 2005 in JAMA that was published and mentioned that the nasogastric tube, patients in advanced dementia having nasogastric tube, the outcomes are in terms of all-cause mortality, institutionalization, and also length of stay, etc. All they are not good. So in your study, actually, do you have any additional information? Can you tell us about the use of nasogastric tube?
Yeah. Are we able to go back to the slides? So I think one of the things that meta-analysis and prior studies did not provide information on were the assessments of speech therapists. And so we actually did a manual chart review and found the speech therapist's records and noted the type of feeding problem that was identified, as well as the severity if dysphagia was present. And we looked to see whether that affected survival. And another outcome we looked at, which I presented this morning, was aspiration pneumonia. And very interestingly, the severity of dysphagia and the type of feeding problem we found was not a significant risk factor for development of aspiration pneumonia or survival.
Okay, thank you, Dr. Yuen. So maybe we end our outstanding free paper presentation. And now we moved to the prize presentation. So it's going to be busy. We are going to have 10 awards coming. So shall we start now? Okay. For the first one, actually, we have the Best Presentation Award at the Inter-Hospital Geriatric Meeting because for 2 years, 2019 and 2020. So we would like to invite Dr. Ko Chi-Fai to present our award to the winners. So the first winner is from Cheung Kwan O Hospital. So it's Dr. Cheng Huai Ping. So congratulations, Dr. Cheng. Thank you. So for the Inter-Hospital Geriatric Meeting 2020 Best Presentation Award, it goes to Dr. Maria Yok Ting. And Dr. Mo, yeah, Maria Mo. She's from Rittenji Hospital. So congratulations, Dr. Mo. Thank you, Dr. Ko. So we move on to the Best Paper Award presentation. So for the Best Paper Award for the Asia Journal of Gerontology and Geriatrics 2019. So thank you, Dr. Tong Yuen, to be our presenter. So the winner goes to Dr. Doris Mills. So she always gets our, cash awards. From Won Tai Sin Hospital. Congratulations, Doris. So for the Asian Journal of Gerontology and Geriatrics 2020 Best Paper Awards, it goes to Dr. Stanley Tam. So our chairman of today's annual scientific meeting. So congratulations, Stanley. Yes, he's from. Yeah, he's from Buddhist Hospital.
This is the first
Thank you. So we move on to another award, the Gold Medal Award Specialist in Geriatric Medicine Exit 2019. So we would like to invite Dr. Caroline Kong to come and give us the prize. The winners goes to Dr. Iki Chen, so from United Christian Hospital. So she also got the outstanding free papers presentation just now. Thank you. So for the Gold Medal Award Specialist in Geriatric Medicine Exit 2020, the award goes to Dr. Stephanie Lee from Haven of Hope Hospital. Congratulations, Dr. Lee.
Okay, now is the time for the presentation of prize to the Outstanding Free Paper Award. So the Outstanding Free Paper Award are named after the first three presidents of the Hong Kong Geriatric Society. So the first presenter would be Dr. Jenny Lee, the president of the Hong Kong Geriatric Society, and this is the Chen Sik Prize because Dr. Chen is not present today. So Dr. Lee would present the prize to the winner in place of Dr. Chen. So the winner is Dr. Tam Yuen Yi Ellen from Tuen Mun Hospital. Dr. Tam, please. Now it comes to the second prize. It is the second president of the Hong Kong Geriatric Society, Dr. Ng Yo Yong. Dr. Ng Yo Yong, please. And the outstanding paper winner is Dr. Jacqueline Yuen. Dr. Yuen, please. Okay. So normally we only have 3 prizes every year, but this time we have 4 papers. It is because they are of equal marks, the scores. So now may I invite the third president of the Hong Kong Geriatric Society, Dr. Ng Lai Seng. Dr. Ng Lai Seng, please. And the first winner of Ng Lai Seng Prize is Dr. Chen Hai Ki Iki from UCH. Dr. Chen, please. So Dr. Ng Lai Seng have to do extra work, have to stay. So the other winner for the Ng Lai Seng Prize is Dr. LEUNG Xiu Biu. I hope I have pronounced correctly. Dr. LEUNG, please. So thank you. And so the prize presentation session has ended. I wonder if the president has some closing for the whole event today, if she wants to say something. It's extra.
So thank you everyone for the extraordinary day. And then, of course, I must thank Dr. Aoyang for the extra airtime that he has given me. I was told that my speech at the opening wasn't heard very well because I didn't hold the microphone close to my mouth enough. But don't worry, I'm not going to repeat it again. I just want to thank again the past presidents, especially the 2 that are among us today. No, is James here? Oh, one more past president gone. Anyway, so I thank every one of you, especially Stanley and everyone else who have worked very hard to make this happen. This is this is the end of our 40th birthday of our society. And I certainly hope that we will have many more years to come. And I hope to meet you, every one of you, face to face. I'm speaking to those online now, if they are still there, and in real person next year, and then we'll have a great big banquet again. Thank you very much.